But I am indeed at NYU in the newly founded Center for Psychedelic Medicine. I've been at NYU for several years, like Anna said, starting with my psychiatry residency. And I went there because I was interested in doing the psychedelic research. So I'm really excited that that worked out and that I'm still there working with really some amazing people. The ketamine work that I've been doing actually isn't in the context of my work at NYU. There, we're primarily looking at psilocybin for various indications and Mdma for PTSD, like Michael and Annie were talking about with you guys recently. But I have this small private practice where I do ketamine-assisted psychotherapy, among other things. And insofar as part of my identity is that of a researcher, I am really interested in exploring some of the other sort of remaining questions around it. There's a lot more in clinical use than we've been able to talk about in the research space. So we'll talk about that a little bit. Just kind of a broad overview. This is a non-competitive Nmda receptor antagonist, so glutamatergic. It was approved by the FDA in 1970 for use as an anesthetic agent. It still occasionally is used in that capacity, especially including in children. I don't know why, oh, there it is. So it has a really good safety profile when it's used in the medical setting. I'll talk about some various side effects, but it's a very safe drug as long as the appropriate people are being selected to use it and are carefully monitored in various ways. And we've heard a lot about it, or I think that at least some of you will have heard a lot about it recently for various psychiatric reasons, but actually the off-label use of lower doses, sub-anesthetic doses for psychiatric problems was reported as early as 1973. And you see up there that it's approved by the FDA in 1970. And so people were noticing quite quickly that its potential value wasn't limited to anesthesia. And part of that meant that it was associated with recreational use. And so that's certainly an issue right now, but back then they were talking about it as a dissociative anesthetic. That's still the way that people talk about it right now. But this is from a letter to the editor from the New England Journal of Medicine, which is a very prestigious medical journal. And this person was sort of calling into question that idea that it's a dissociative anesthetic. He said, differences between LSD and ketamine relate primarily to the rapid onset and short duration of the latter. So they're very similar, other than how quickly they come on and how long they last, right? With LSD, you're talking like 10 to 12 hours. With ketamine, you're talking 1 to 2 max. Thus, the pharmacologic classification of this drug apparently is determined by the purpose for which it's used. Dissociative, if it's being marketed and administered as an anesthetic, and hallucinogenic, if it's employed illicitly. So he's saying, there's something a little disingenuous about this whole idea, that we can talk about it as a dissociative anesthetic when people really are using it for its psychedelic properties, and that those, there's quite a bit of overlap between those two. And so this is something that, we continue to be talking about or thinking about, but that was recognized really early on. And when we talk about the non-ordinary states of consciousness, that's what I mean by NOSC, that are induced by ketamine. I like to look at this graph. So the red is psilocybin, the green lines are ketamine, and then the blue line is Mdma. And so those are the lines, and you have down here on the x-axis various aspects of the 5-dimensional altered states of consciousness questionnaire. It's one of the pretty standard, it's very broad, but pretty standard scales that we use in psychedelic research to characterize the different dimensions of the acute psychedelic experience. And so I want to draw your attention here to some of the ways that these overlap with each other and some of the ways that they're different. So here, for example, this is spiritual experience. And there's, no significant difference between ketamine and psilocybin here. And psilocybin is definitely one of those substances where, people, you hear about them sort of getting smacked over the head with God. Another one is insightfulness, right? So something that you'll hear often in the psychedelic space is that I had this experience and it gave me a real insight into something that I hadn't been aware of before. And you see that there's a lot of overlap there too. Complex imagery. So insofar as these are hallucinogens, and people will say, oh, well, they're not technically hallucinogens. And it's true because, they're not fixed and because, there's some sense of what's reality and what's not. But insofar as there is visual imagery, even with your eyes closed, these two are both, psilocybin and ketamine are both quite a bit higher than MDMA, which is, some people don't even call it a psychedelic and nobody calls it a hallucinogen that I'm aware of anyway. But there still is is something of a difference between psilocybin and ketamine, with ketamine a little bit lower there. And then for altered state of consciousness, they're essentially the same here too, psilocybin and ketamine. And so people, when they're, in a psychedelic kind of ketamine state, they are very, very altered. And we'll talk more kind of about what that looks like in a little bit. The oceanic boundlessness, the sense that, that we are boundless, that we are participating in the whole of things. Some aspect of that or related to that is ego dissolution. There's a lot of overlap between all three. And so insofar as, as these are all psychedelics, there are certainly differences between them, but it also, if you look at a graph like this, it also sort of makes sense why we tend to group them as psychedelics, even though mechanistically, they're quite different. And in terms of subjective effects, some of them are also quite different. A couple of things that are different for ketamine here is disembodiment. And so when people talk about it as a dissociative anesthetic, they're talking about the sense that that you are outside your body. And I'm going to talk a little bit more, or maybe in the Q&A, I don't remember if I said anything specific about this. But there's the sense that you are outside your body, though what that means can look quite different depending on what dose we're looking at. But that's essentially what dissociation means. And then disembodiment, in some sense, people might feel like they really aren't a person. So if someone takes psilocybin, say, there is still a them there who can be engaging with someone else in the room, looking at me and saying, Kelley, somebody said to me, a participant said to me relatively recently, Kelley, I'm looking at you and you look like this blue-faced God with 8 eyes. That is not going to happen on ketamine. And, that there is still a them perceiving other as different. And then the final one, impaired control and cognition. It's going to be a lot more difficult for somebody who's high on ketamine to be walking to the bathroom, to even know that they might need to use the bathroom, to be able to think straight, than somebody think straight is not, to kind of sober up in a moment in a way that somebody on other psychedelics may be able to. It is
Kelley.
Yep.
Could I ask a question about that last graph?
Uh-huh.
How are the dosages compared? How do they make it equal to where you can graph them against each other?
No, it's a great question. And how are they compared is tricky. I'm pretty sure that the psilocybin dose here was the 25 milligrams, which is pretty standard. And that the ketamine was 0.5 milligrams per kilogram. I think that the selection of those doses was simply that they are pretty standard. And, if somebody has read this paper more recently than I have, they can certainly correct me if I'm wrong here. I don't remember at all what the dose of MDMA was. But I think because those are the ones sort of most commonly reported in the literature, the idea was that they would start there. But certainly, if you changed the doses, I imagine that to some degree anyway, you would be changing these curves. So impaired control and cognition would certainly go even higher for ketamine, for example, but probably also for the psilocybin. And then things like imagery, for example, if you give a high enough dose of ketamine, then it's more, than it is like an anesthetic dose in a deeper way. Like you're not here. And so that would likely go down, or at least the imagery that you would be able to remember when you came back into your ordinary state of consciousness. I would imagine that any number of these could change, but not necessarily in predictable ways. So it would be really nice to kind of do dose response curves and then to compare them in that way. But I don't think that anybody's done that. So Anna, maybe that could be you. Did that answer your question?
Yes, thank you. That was good.
Kind of I don't know the answer, but again,
I like those.
Okay. There will be a lot of those. So it can be abused. So here is, this was a landmark paper from 2010 that was looking at all different substances of, let's say, misuse or abuse, certainly some of them illegal, and looking at the overall harm score. So in blue here, we have the harm to users. So if I use, alcohol, for example, how much is it affecting my liver, say? And then the red is harm to others. So if I use alcohol and then I go out and drive, I can wreak all kinds of havoc in that way. And so you see down here on the right, very, very low risk, or at least very low relative risk of classic psychedelics like mushrooms or LSD, and then also of MDMA. And then ketamine is a little bit higher up here, and the majority of that kind of risks or harm score is harm to self, and we can talk about some of the side effects in a couple of minutes. But still, none of these, including ketamine, are anywhere near alcohol. Ketamine's a 15, alcohol is a 72. And so, when we think about ketamine in the context of misuse and abuse, the risks are significantly lower. Alcohol kills. And speaking of side effects, so there's short-term side effects in terms of what is happening, say, in the office when I'm giving somebody ketamine. Those would be things like increase in blood pressure, increase in your heart rate, but those are self-limited. So by the end of the session, those should have returned to baseline. There is this dissociation and depersonalization, right? The sense that you are outside your body, you aren't who you are. And those are things that, some would consider side effects, like adverse effects. And others would say, nope, that's the whole sort of therapeutic mechanism. So we'll talk a little bit about those two camps. And then nausea, rare vomiting, headache is pretty common. Those are also possible even just within the session. These can also be seen when it's used in the recreational context as well. And then longer term, that's something that we know from people who are chronic users. Though these are, they're using at a much higher level than we'd be using in the medical setting. And so using like that, and like really much higher. So let's say I give a dose of 100 milligrams. They would be like, I had somebody come to my private practice who was using like 1.5 grams a day. And so there's a really vast difference. And so he was snorting it. And so the bioavailability is different. It's like 40%-ish. But even so, it's a vastly higher amount than, our patients are using. So, but chronically used, there are things like a chronic abdominal pain. You can get liver injury, inflammation of the bowels. And then, also problematic, and certainly one of the things that, that people think about more in the medical literature is inflammation of the bladder. And sometimes that's mild, just kind of feeling like their bladder is irritated, painful. But then you can also sort of have ulceration, sort of degradation of, the cell lining of the bladder, and that's much more problematic. But we really don't have a good sense of what, the adverse side effects of of ketamine would be when it's used in the biomedical setting, because it hasn't been used that much, in since it kind of came back into the mainstream. So it's not just the amount of ketamine, but also kind of the duration and people getting kind of maintenance doses and things like that. That hasn't been happening for long enough to have a real clear picture of what the long-term adverse events might be. And then, in terms of that prior slide, there is a potential for misuse and dependence. It is higher on, on the scale than psilocybin, say. Part of that might be mechanistic. Part of that might be that it's very, it's very short acting compared to LSD. And so there would be maybe more potential to be using it without really having to carve out an entire day for yourself. And then certainly, and we can talk about this later if anybody asks, kind of the duration of the journey sometimes affects how people, how people experience it and how much they have to integrate. And so if ketamine is a little bit, faster on that end, then it's not like people are so worn out because they really have had all of their psychological experiences right then and there over the course of the day. Maybe that leads to increased use. Some people also talk about it. I heard somebody describe it as it's like, this in the recreational setting. He said, it's like drinking, but you don't have a hangover. And so that was part of why he was drawn to it. So in terms of contemporary research, like I said, so, first people were noticing its effects in 1973, like psychiatric effects potentially. But, more recently in this contemporary research landscape, we study things more rigorously. And recently it's been studied for the treatment of depression. That's certainly what has gotten the most notice. So that work started happening at Yale and the NIMH back in the late 90s, and then started getting published in the aughts. There have been many since then, both in terms of unipolar depression, so just major depressive disorder, bipolar depression, what we call treatment-resistant depression. So people have, tried multiple medications already for their depression. It hasn't worked, and then they get ketamine. Suicidality is something that people have looked at that it can be very, very useful for. And then more recently, in various paradigms, people have started to study ketamine for PTSD symptoms, and then various substance use disorders. So a couple of decades ago, people were already looking at it for alcohol use disorder. They were looking at really quite high doses. And then more recently, cocaine and heroin, or sort of in between heroin. And then much more recently, it's been looked at Columbia for cocaine use disorder. So one of the nice things about it, and this is true when we think about it, whether for depression or for suicidality, if somebody's acutely suicidal, chances are they're already in treatment in one way or another, often with an antidepressant. And so if they come into the emergency room and they're acutely suicidal, and you want to give them something, it's going to be really important that that thing not interact with what they're already taking. And so one of the nice things about ketamine, among many others, is that it really doesn't have major interactions with other psychotropic medications, other medications that are used, for mental health. And so, And so I'm going to talk, kind of for the rest of this time about different ways that ketamine is used. There's a biomedical treatment paradigm, and then there are kind of a couple of others that are grouped as ketamine-assisted psychotherapy. And all of the research that's been done systematically at this point, almost anything you're going to look up on PubMed, say, has used what we call this biomedical treatment paradigm. And so the overall approach to that usually is that people are in an outpatient infusion clinic. And so they have an IV in their elbow, and they're getting an infusion through there, usually outpatient, though, the early studies weren't. People have also studied intranasal. And one of the things that people like about that, one of the things that researchers like about that, is that there's less dissociation. I shouldn't say researchers, I should say researchers in this biomedical paradigm. Less dissociation, and if that's considered an adverse effect, then they're happy. And what they're trying to do there is really minimize the non-ordinary state of consciousness. And you do that by, starting at a lower dose and then infusing it over a longer period of time. And usually there's close medical monitoring. People will be hooked up to a blood pressure cuff, heart rate monitor. And then, if you look into this at all, it is not cheap to get this kind of treatment. And usually, what they say is you're paying for the nurses, you're paying for the IV, things like that. But ketamine itself is like dirt cheap. One of the problems with the biomedical model, if you're somebody like me, which is to say somebody who is really interested in kind of our inner lives and the extent to which our inner lives affect, the things that or manifest as symptoms, maybe. There are some limitations to this model. So there isn't any ketamine specific psychotherapy. So there's that. And it's interesting, in some of the earlier studies of ketamine for depression, sort of in that biomedical model, patients were often allowed to keep seeing their therapist, and many of them did. But here I'm talking about there's no ketamine specific psychotherapy, and I'll talk about a couple of different ways that we can do that in a sec. And the overall framework, they're focusing on neurobiological mechanisms. They're talking about things like Nmda receptor antagonism and neuroplasticity, BDNF, things like that. That's the framework that they're approaching the work with. And then it's possible that there's a less durable effect with this biomedical model than others. But there have been no head-to-head comparisons. And I think that when people say things like this, they really have to think about, the doses that are being used, are they comparable, and things like that. And the research has not been done at all, and certainly, or at least not in a rigorous and systematic way. Many of the questions, though, really haven't been looked at all. So the top left here, like I said, is sort of the context for that biomedical model. And then there are others. So when we're talking about, well, this is fine, about other models. So we would say two others, the psycholytic, or some would say the relational model, and I'll talk about that. And then the psychedelic or transformational model. And so those are not going to be in an infusion clinic. Those are going to be in a space that, is much like you'll have heard of from Michael and Annie Midhofer, is what's being done with MDMA. It's relaxed, it's a living room-like setting. It's specifically designed not to be clinical. And then these last two, we group into the terms ketamine-assisted psychotherapy or ketamine-facilitated psychotherapy. And now I'm just going to talk about both of them. These three treatment models differ in terms of the route of administration, the dose, the infusion rate, how much they care about context, and then also what the role is of the clinician. Is it just a doctor who is writing the prescription and a nurse who's hooking up the IV and they leave you there? While you're having your relaxing couple of glasses of wine experience, or is active therapy happening, or, is somebody essentially being a sitter, a facilitator for the psychedelic experience? So first, I'm going to, I don't know what happened. So first I'm going to talk about the relational model. Others call it trance, or like I said, psycholytic model. Just kind of the basics of this. Usually what they're using is sublingual lozenges. You put them under your tongue and you generate a lot of saliva, and then you swish it around in your mouth, and you're really trying to get that lozenge, exposed, or to get all of the mucosal surface of your mouth and under your tongue exposed, so that it can be absorbed into the bloodstream. It's usually a lower dose. And then in this relational model, it's usually within the context of an ongoing psychotherapy. So somebody has their kind of long-term patient, they know them well, and then this is designed really to facilitate that, the experience of psychotherapy, usually taking place over multiple sessions. And what's the experience like? Here, the patient, who's there talking with their therapist, is fully conscious. They maintain their awareness. Often they are talking through much of the session with their therapist, usually about issues that they have agreed to address that are difficult to address, without something to facilitate it. like you see again with the Mitthofers or with the MAPS trials with MDMA for PTSD. People can, notice, observe how their mind is wandering, without getting really carried away by it. And the idea, like I said, is that it's facilitating psychotherapy during the session itself. And then, so that's the relational model, which, this is a psychedelic science course. And so I'll talk a little bit more about the psychedelic model, otherwise known as the transformational model. And so the basics of that are, at least compared to the relational and the biomedical both, we're usually talking about a higher dose that's usually delivered via intramuscular injection. And the nice thing about that is it means that if somebody's low risk, like they don't have a history of high blood pressure, for example, or they're below a certain age or did I say low? If someone's low risk, below a certain age, et cetera, uncomplicated medical history, then I'm going to feel comfortable administering this, this very safe medication just in my private practice office where I don't have a crash cart, say, because it's intramuscular injection rather than an IV. I have no idea how to insert an IV. And, that would, the IV sort of makes for a more medicalized setting that I'm not interested in creating in my office. The session is usually accompanied by music with the patient wearing eye shades. And so it's very inward oriented. The studies that you see of psilocybin assisted psychotherapy are very much like this. So again, this is that psychedelic model. The psychotherapy with this often, and you'll hear people who don't really use it say always, but I wouldn't, often it's only before and after the experience. So it's preparation and integration. Again, that's very common to what you see with psilocybin assisted psychotherapy. It's not ever really going to be during the peak experience, the first 15 minutes, say, because people essentially can't move and might have forgotten that they, have a body and a mouth with which to be telling you anything. I say that some psychotherapy can happen during the experience because people have a really broad range of responses and kind of tolerance to ketamine. And so I can give the same dose to two people and one of them will be completely out. And the other will be, talking the entire time about their experience and integrating it really along the way. And you'll see that actually with psilocybin too, even though people talk a lot about sort of the full-blown mystical experience, there can be a lot of action, a lot of talking and processing during the experience itself also. And then there's this post-ketamine psychotherapy also. So it might not occur on the same day. At least in my practice, often it starts then and then continues with integration, in an ongoing way. So for this case, people often will come in and say, I'm really depressed. And I think that, if I have an experience that completely alters my state of mind, I will access some part of me that I think could be relevant to the therapeutic process. And so, the visions that they have are sort of the starting point for the things that you're going to discuss in the integration, that it's giving them material from their inner lives that, that could give them a hint as to what might be important for them to be changing about their outer lives. And so these are just some experiences from my patients, or I guess I'll talk about that on the next page, but just kind of across the board, many people really do have vivid visions, eyes closed, in which they experience or, cosmic and mythological realms. So it can be kind of spiritual or ensouled, kind of expansive or really grounded, and underground. People can have birth and death experiences. Sometimes full ego dissolution, a sense of real boundlessness, like we talked about on that earlier slide, comparing it to psilocybin and MDMA. Being outside time and space, those are the boundlessness, the outside time and space, those are really common at higher doses. And, I should say that much like any psychedelic, at least any that I've worked with, the sessions can be really challenging for some patients and, blissful for others. And that can be That can be hard to predict also, and dose dependent as well, context dependent. There are a lot of various factors that might contribute to that. So here, just from my practice, and here we're talking about 0.8 to 0.9 milligrams per kilogram intramuscular injection. The biomedical model tends to start at 0.5, and that's administered IV. But this is by no means the high end of the psychedelic spectrum. So people are, giving injections of up to like 2-ish milligrams per kilogram, some even a little higher. But like I said, if you get past a certain point, people are going to be having missing time. It's too much that anesthetic dose, that anesthetic effect. And so you're not going to be able to, to recall any experiences you might have been having if you were having them at all. And so that's going to defeat the purpose of it. So I had one patient, she said, in her experience, I was a serpent on the water and my breath was the ripples. I was acquiescing to the dynamism of existence. We had been talking before about a book by Josef Pieper, and that was one of his lines. Someone else said, I kept being wrapped in love and kindness and wisdom. It was a holy place, a secret garden. I was saying there's darkness, but there's more light than darkness. And then someone who had a tendency to, very obsessional thinking, he said, between my fear and the inner critic, I felt there was another way. And so really just getting access to an alternative, something that, a stillness that they could then hold on to, knowing that it was possible in the future. In terms of the dissociation, this person said, my whole body was being stretched until I dissolved into the universe. And I think that line, I really like it because it kind of speaks to this sort of a spectrum between dissociation and ego dissolution. So just kind of to summarize some of the core differences between these two ketamine-assisted psychotherapy paradigms are the dose and route of administration. So you can give a low dose of ketamine via injection and do the ketamine facilitated psychotherapy within the relational model. It tends to be less common. How the psychotherapy is used, is it a lot of active work during the session or more before and after? What is the subjective experience like? Are you softening the defenses so that you can talk about really difficult things with your therapist? Or are you trying to, have a real transpersonal experience that you're hoping to kind of integrate into your regular life? The dose will really affect those things. And then how do you interpret that experience as well? How do you make meaning from it? So those are some of the differences. And then again, bringing back the biomedical model versus those two together, some of the differences would be, what's the framework and what are the values? So the framework meaning kind of a biological or more of a kind of broader psychospiritual orientation to wellness and depression. And the importance of set and setting, how much are we preparing somebody for an experience? How much attention do we pay to the environment in which that experience is taking place? The dose and the route, like we've talked about. How do we interpret the acute effects? Are those an adverse side effect, or is that sort of the healing, mechanism? And then what is the clinician doing during the experience? Are they, just tending to other people in the clinic because you're just enjoying your experience, or are they actively working with you in psychotherapy, or are they holding space for you in a deeper psychedelic experience? And then that speaks also to kind of the value of psychotherapy. So within that biomedical model, there's certainly no requirement that somebody be in psychotherapy, and the psychotherapy isn't ketamine specific. I've had people come to my office after having really having infusions in very biomedically oriented centers, and in which they were told, don't pay attention to what happens. This is a drug. It's going to make you feel better, the end. And so there was no sense that non-ordinary state of consciousness could be relevant to the healing process. It was purely biological. And then the integration experience. So we really do know that even in the absence of psychotherapy, ketamine has an effect on mood, right? Most of those research studies that prove that it's so effective against depression and suicidality, they're not using psychotherapy also. And so there is, value in that model. But even so, there's this question, when we medicalize things, are we kind of missing an opportunity to talk about other kinds of meaning in life? And so I really like this picture, which I took from an article in The Atlantic that I don't think had anything to do with ketamine. But when I like this because, in terms of the biomedical model, so this is a brain with some roots and some flowers on top. When we talk about the biomedical model, we're really focused on the bottom 2/3, right? We're focused on the brain and kind of the downstream mediators of that, whether it's the, peripheral nervous system or other things. When we're talking about psychedelic medicine, we're looking at this whole picture, or at least when I'm thinking about it, that we're talking about the brain and the rest of the nervous system. And that's really important. But that those things underlie the sort of fuller experience of human blossoming. And so within the context of ketamine assisted psychotherapy, in whichever model, we're caring about the blossoming. We're not simply caring about the healing of depression. We're talking about, the expansiveness, the expansion into a fuller way of being in the world. And so, I really don't think that these have to be kind of groups that are pitted against each other, even though it definitely can look like that sometimes, and definitely people take that approach. But I really don't like to look at it that way. And so here's a lovely quote from William James, from the Varieties of Religious Experience, which some of you probably have read. He said, when other people criticize our own more exalted soul flights or mystical experiences by calling them nothing but expressions of our organic dispositions, we feel outraged and hurt, right? So if I have this full-blown mystical experience and you tell me, yeah, but Kelley, that was just your Nmda receptors being blocked, and there are definitely downstream effects that that happen, that it's nothing but an expression of what your brain is happening. That does not feel right to sort of my experience. And then he continues, sort of the reason that we're feeling outraged and hurt is that we know that whatever our organism's peculiarities, our mental states have their substantive value as revelations of the living truth. And we wish that all this medical materialism could be made to hold its tongue. And so again, he's not objecting to the idea that we have an organic disposition. He's not objecting to the idea that, that the brain matters. But he's saying that, he's talking about blossoming, right? He's talking about sort of how do we reveal our truth, the truth that is alive to us in those experiences. And that medical materialism really tries to undermine that by talking about nothing but. And so again, he's saying all of these things matter, and that we should be tending to that garden, which I think applies very much to the kinds of work that we're doing here. And I really like this line also by Poincaré. He said, science is built up with facts as a house is with stones, but a collection of facts is no more a science than a heap of stones is a house. That there are lots and lots of parts. And what we are looking for really, when we think about wellness, when we think about meaning, I think that what we're really looking at is a whole, an experience of wholeness, of union, and that that if we're just talking about science, then we're talking about what we're talking about is parts, is those stones. And when we're talking about kind of the fullness of human experiences, in this more kind of holistic psychospiritual orientation that doesn't deny our organic disposition, we're talking about a home. He would say your house, and I would say that really full attention to all of that is what makes a house a home. The interpretive experience. And that's all I got. Raquel Bennett was the first person who introduced me to this sort of idea of the three paradigms, though certainly, she was talking about, what is in use. But I am very grateful to her and for her teaching along the way. I am grateful to NYU and the people who have funded our Center for Psychedelic Medicine and the research training program. And then various other CAP teachers and supervisors. I first trained with the Ketamine treatment center, training center with Phil Wolfson and Julian Andrews, who are amazing. And then Jessica Katzman, Harvey Schwartz. Those are both, fantastic people who have been really instrumental in my journey as a healer. Gita Vade also. And then, there's this Google group. There are just a lot of wonderful people. And then insofar as my experiences at NYU, particularly with psilocybin-assisted psychotherapy, though also from Annie and Michael in terms of, the MAPS training, those have really informed what it is to me to be a psychedelic healer, let's say, and to be working within these models. So now I will stop sharing my screen and hopefully you guys maybe will have something to talk about. You don't even have to ask, you can give me new ideas. That's cool too.
Well, thank you so much. That was a great lecture. Actually, some students prepared speaker questions in advance.
Great.
So if those students want to ask questions now, you guys can go for it. Or if you want me to read it for you, you can put it in the chat.
Hi, thank you so much for speaking with us today.
Thanks for being.
One of my questions was, I know you touched on this a bit, but the challenges sometimes of having a session where you're doing ketamine-assisted psychotherapy. Could you go a little bit more into that and maybe what you found challenging, like training to be certified in ketamine-assisted psychotherapy?
Yeah, that's a lovely question. So in terms of challenges, I think that it is challenging for people who are unfamiliar with non-ordinary states of consciousness to enter into that. Because if they're not familiar with it from sort of a different, portal, then it's really hard to prepare for that kind of experience. They can read Michael Pollan's, book about psychedelics generally, but that really isn't the same, obviously, as entering into an altered state. And so if they haven't had an experience, a deep kind of meditation that kind of enters into something, if they haven't done holotropic breath work, for example, then it can be really hard to describe things in a way that later resonates with them. And for ketamine in particular, you go from, it's almost like you hear people describe with DMT, like it's a very, very fast onset if you're using the psychedelic model with the intramuscular injection. And so there's, it's like a kind of a takeoff that can be incredibly disorienting to people and very stressful. I have had many, many, many people ask me repeatedly during that launch, am I dead? Are you sure I'm not dead? Kelley, am I alive? Kelley, will I see my family for dinner? That there is a real loss of reality that can be really anxiety provoking for people in the beginning. I'd say that people who suffer from a kind of, whether it's obsessive compulsive disorder or just more of a kind of obsessionality, sometimes it can be difficult for them to settle into the experience. And so there is then more coaxing that might be needed or grounding that might be needed. Reassurance also that they are, that they're safe, that they will come back. In terms of, you asked me about training, I think I don't, much like with preparing a patient for any altered state, I think that it is really hard to for any kind of just didactic or theoretical, educational experience to take the place of spending a lot of time sitting with people. You get comfortable with altered states, you get comfortable with just how different those altered states can be, just how safe someone can or can't be, kind of depending on what the context is, how I maintain their safety, what do they need? How do I maintain my own groundedness also, in terms of, I don't want to freak out. That would potentially be a disaster. But again, I want to make sure that people are safe. And so kind of recognizing what might an emergency look like. I think for people early on, especially if they're not working with somebody who's more experienced and kind of in an apprenticeship model, it would be really hard to do that. And so if you do kind of just a few days long training, and then you think that you can just dive into it by yourself, and you don't have a lot of experience with like harm reduction, like Zendo project, things like that, then it's going to be a lot more difficult to hold space generally, to be a safe container when somebody is, getting very anxious or very upset in one way or another. And then also to have a real good sense of what the actual safety risk is and how you can mitigate that risk on a moment-to-moment level. Does that answer your question?
Yes, definitely. Thank you so much.
Sweet. Yeah, thanks for this wonderful talk. I suppose I'll ask another question. Yeah, so you kind of already touched on this, but how do we classify ketamine in relation to the classical psychedelics, and how does that inform therapeutic practices?
And just when you say classify, what do you mean?
Well, I don't know. That's a good question. I suppose like
I'll just riff off of that.
Yeah. I mean, well, just to provide a little more context, you brought up the graph with the different effects, and it seems like there are some effects that are unique to ketamine in terms of like disembodiment and things like that. So I'm wondering, like, how does that inform our classification? Is classification even necessary? How does this inform how we do therapy?
Yeah, I think those are all terrific questions. And I'm probably going to go off on all kinds of tangents that I hope are related to your questions, but you might have to sort of rope me back in. So I'm going to talk. So usually when people classify psychedelics or sort of parapsychedelic drugs, they're talking about them in terms of their structure, their molecular structure, and or their sort of the receptors that they're acting on. So ketamine is acting on the Nmda receptor, and classic psychedelics are acting at least primarily on the serotonergic 5-HT2A receptor. And so, that's kind of one of the broad ways that they're distinguished. Classic psychedelics are also called classic hallucinogens. And ketamine is, almost across the board called a dissociative hallucinogen. So that's kind of trying to classify them in terms of these subjective effects, like you mentioned with the graph. When I think about like dissociation, I've never heard, so sometimes with psilocybin, people can have very embodied experiences, but I don't know that I've ever heard people talking about their bodies being sort of stretched until they merge with the universe, right? That they're sort of them almost observing the process of ego dissolution as it's happening, of being sort of pulled apart into wholeness. I think, that's part of why people are talking about it as a dissociative hallucination or hallucinogen. Even when somebody sort of is having what I would call a full-blown mystical experience, there's still with psilocybin kind of a them there to be telling me about it. There's a them there who is almost recognizing, their union with, with the divine, let's say. Whereas in ketamine, at least in what I've seen, and there really is such a broad spectrum of what people can experience, but at least in the many people that I've seen who are having kind of a full-blown mystical experience, they really are the divine. They are nature. That they, are genuinely having that experience in what feels to them like an embodied way, even as they're, totally disembodied. And so I'm just noticing this question in terms of challenging experience. Yeah, I'll get to that too. So that in terms of the difference, in terms of similarities, and there are many similarities. So I'm going to forget to talk about MDMA, so I'm going to talk about it real quick just now. MDMA, lower doses of ketamine can be a lot like MDMA. They can increase an experience of empathy, of closeness. It's commonly used, not in a way that it's been formally studied, but a lot of therapists who use it in the context of couples therapy, much as has been studied with MDMA. And much like MDMA, you'll hear people talk about how, it sort of decreases, like the activation energy to talk about difficult things, whether it's in the context of couples therapy or own therapy, is lower. Sorry, I don't know if you guys can hear, I'm sorry, is lower, because sort of that fear response is attenuated, it's dialed down. And so they have more access to, there's less resistance to that difficult material, because it's not bringing up all of this fear and, and sadness in the same way, in a way that's really overwhelming to them. So that can be very similar to MDMA. At higher doses, I definitely think of, more of the overlap between ketamine and classic psychedelics. So insofar as ketamine, is often described as having kind of cosmic experiences be quite common, sure, and maybe disproportionately so when we're comparing the two. But ego dissolution absolutely happens with both, even though, like I was saying, kind of the quality of those might be a little bit different. I'd say it's less common in my experience for people who are on ketamine to have, very clearly autobiographical imagery and experiences. I don't even mean experiences, imagery. People who are on ketamine, they might still have visual experiences that are relevant to autobiographical issues. But in terms of kind of having the visions be of that, I would think more kind of psilocybin, ayahuasca, classic psychedelics. Whereas ketamine, I would say more, there might be symbolic images, archetypal things that kind of bring them back to relevant experiences in their lives. Yeah, so that would be another difference. I don't know. I would say, yeah, this is one other really important thing. Like I said, ketamine's just so fast, not DMT fast. You're not like there and back, in 15 minutes, having seen creatures who, tell you the truth about the meaning of life. But like the peak experience, like you're feeling it within a couple of minutes, and when I say you, or when I say I don't mean those things. Then you're coming back, you're past the peak, say at 30 to 45 minutes. And then, you're in sort of this a little bit disinhibited state. Again, good psychotherapy can be happening there after a psychedelic experience with ketamine. But that's all happening in the space of a couple of hours. So that is very different from a journey on psilocybin lasting 6-8 hours, or on LSD lasting, 10 to 12 hours. Just kind of what can come up, what is it? Honestly, being in the room at all with someone for 6 to 8 hours, that's a kind of, with no drug on board at all, that's a really special experience that neither patients nor therapists tend to have ever, and so that can be like its own kind of journey. And then you introduce a classic psychedelic and really all bets are off for where that journey can go. And I do think that the duration of that can affect how deeply and in how sustained a way somebody can be entering into a space. I know that wasn't very articulate, but did I hit on some parts of the question at least? I should write these things down before I start to answer them.
Yeah, no worries. That was really interesting. And then Anissa and Kelley, I have a follow-up if it's all right. Yeah, so I was wondering, how do you respond to people who might be skeptical of ketamine because it's not quote unquote natural?
Yeah. I wonder about those people. Are they also skeptical of LSD? Because it is not natural. Virtually all LSD is going to be generated in a lab even now. So they can say yes, but wave anyway. But yeah, I think there's certainly this, there's this divide in the community, people who really want to talk about plant medicines, decriminalize nature, decriminalize anyway. And I think it's tricky. What I'm interested in is what helps people heal. And so, there are people who are really into, this is going to be some terrible analogy, so please don't jump on me, but like really into veganism and are strong advocates for how important that is in so many ways. And that's great. I believe you if that's what's working for you. Maybe even your doctor recommended it. Certainly your doctor shouldn't have to recommend it, but that's not going to be the right diet for everyone. People have different kinds of nutritional deficiencies, say. Ketamine is extremely useful for people who are acutely suicidal and people who are really depressed. And even though there are studies of psilocybin for depression that are happening right now, I won't say where my money is. I will just say that in my experience, ketamine is extremely helpful. And so insofar as people who are advocating for plant medicines to the exclusion of other things, I just wonder whether they would be cutting people off from these wonderful, healing medicines. I do think that it's worth noting that ketamine has a higher abuse potential. I think that is worth noting. But yeah, I mean, I can, it's hard. I don't want to get into turf wars. So that's part of why I'm hedging, but I also don't believe in, I don't want to get into them because I don't believe in them. And so I tend to struggle when I experience people as particularly rigid, which they can be in any direction. So if you want to ask a follow-up question that forces me to get more concrete, then we can do that.
Yeah, no, that was great. And thank you for including those philosophy of science quotes in your presentation.
Oh yeah, of course. Oh my God, I have 25,000 more if you'd like them. Was it Garza who said the history of science is science? I think that having a perspective of how our worldviews fit into the wholeness of things and the extent to which our lens really is a lens, right, through which we experience the world. And I think that is so important. And I think that both the history and philosophy of science really speak to that. And that not having any sense of that history and of the philosophy really does everybody a disservice, right? That's how we get into scientific materialism and pure reductionism. If you think that this way of thinking about the world, that you might be learning about in various neuroscience classes that are, very kind of biologically oriented, if that's all you think it means to to be investigating the world, then you are missing out on a lot of wisdom. Again, lenses are really important, and I think different lenses can approach things from different orientations, and different lenses have, different focal lengths, right? And so what they're going to be bringing into focus is going to be quite different, and it's going to really depend on kind of what's the level, what's the altitude that we're looking at here. And if we want kind of a full perspective of things, I think it is worth knowing about and using, or at least not completely dismissing or trying to invalidate the lenses that we're not familiar with. Yeah, sorry, you did not ask me to say that, so thank you for indulging me. I'm looking at some of these comments. Is somebody going to read these to me, or should I be following these? I'm like a magpie. I can't, focus on like one thing.
I can ask the question. Yeah. So the most recent question is, have there been medical studies on other dissociatives like DXM, PCP, or DCK?
So DXM, yes. I think it was Roland Griffith's group at Hopkins who looked at, who compared, I think it was just the two of them, but there could have been a control, compared DXM, dextromethorphan, which is the active ingredient in Robitussin, to psilocybin, and saw a lot of overlap there. I don't remember if they had to be naive to hallucinogen, like have no prior exposure to hallucinogens. I don't remember for that study, but that there was a lot of overlap there too. It would make me a little nervous, and maybe just because I have seen plenty of people in the emergency room who are, robo-tripping and having very challenging experiences. I saw an earlier question that was asking about sort of challenging experiences versus bad trips. And I think that, often people are using DXM outside, a healing context. And maybe that contributes to the fact that I've seen many of them in the psych ER. But also the abuse potential is something that concerns me. What was the other one that was said? I don't remember.
PCP and DCK.
I don't know what that is. What's DCK? Anyway, I'll just talk about PCP for a sec. So PCP2 does make me nervous. You've heard about people being able to like turn over cars on PCP. It does have pretty extraordinary effects. And I don't think that I'm making it up, that one of the way, like the sort of part of the history of ketamine and its discovery was wanting to find a dissociative that didn't have kind of the quite as staccato-mimetic, kind of psychosis mimicking effects of PCP. So it is definitely kind of a level above. It is much more kind of acutely altered, at the doses that people would be using, on the streets, than ketamine would be, and that the risk associated with that is higher. So I don't think that anybody, at least recently, again, outside the kind of back in the day, looking at anesthetics, I don't think anybody has thought or has looked at PCP for therapeutic uses, or even, I don't know about comparing them. I think, if we were talking, if there's a stigma associated with kind of ketamine because it's not a plant medicine, the stigma associated with PCP would be like infinitely higher, just because of kind of what people look like when using it recreationally. That being said, I don't know if some of you have heard of Carl Hart's new book. So he is a brilliant guy at Columbia who very much believes in decriminalizing all substances. And he might very well, he obviously would be including PCP in that. And so it's certainly possible, and he's talking about how he is a recreational heroin user who does not have a dependency problem. And so it's entirely possible that there are people in this world who are using PCP in that exact same way. It's just they're not going to come to my attention. And so, there's some sort of selection bias there. But yeah,
Hamilton's Pharmacopoeia,
brilliant.
I think did one on PCP and went to a guy's house who was really, really into it, and he seemed fine. I mean, he was a little weird, but he seemed fine medically.
Aren't most interesting people a little weird?
Yeah. Yeah. Also, DCK is DXE, deschloroketamine. So the internet told me.
Did Hamilton say anything about it? If so,
No,
I'll learn about it. But
I haven't heard of it.
I've never heard. I'm not that with it, I guess. Sorry.
Did you mention MXE also?
I did
No,
not.
that's a common alternative.
I did not mention that, nor do I know anything about either its use or abuse. Sorry.
Well, there's another question from earlier. Amanda asked, does ketamine not interact much with other psychiatric meds because it's a non-competitive inhibitor? ?
That's a good question. My thinking would be that it doesn't interact with other meds because it's not acting, at least directly, on the serotonin system. And so many psychotropic medications do. And so that would not just be medications like, like Prozac, SSRIs, but also like there's an anti-anxiety medication called Buspar or Buspirone that's acting on the 5-HT1A receptors. And yeah, there's this serotonin system is important, though part of why we think it's so important, in terms of mood and things like that, is that, we notice these drugs have an effect on animal models. We test them out in people, and then we're like, okay, so serotonin must be, since it's affecting animal behavior that we think is relevant to depression, it must mean that the system is also relevant. And so you get a lot of these kind of Me Too drugs, right? And so I think that that's how, the majority of psychotropic medications, at least that I'm using, commonly involve the serotonin system, that's sort of what the idea has been about what's relevant. Glutamate, though, we are increasingly discovering is very relevant to mood. That's why those folks at Yale and then later at the NIMH started studying it again in the 90s. They were trying to test the glutamate hypothesis of mood. And so sort of, I think that it's because of that completely different mechanism that it's not going to be interacting with the two, I think.
Okay, we have another question that Anissa asked, what has been the most rewarding aspects of having your own practice, just specifically one that specializes in ketamine-assisted psychotherapy?
Oh, that's such a lovely question. It really is such a lovely question because I really do love the experience, really, of doing what I would characterize as psychedelic medicine, though not plant medicine in this case. That I really do, as somebody who is psychospiritually oriented, sure, I am trained in neuroscience, but in terms of how I experience the world and how I experience my patients, it really is in a holistic way that doesn't divide people up into, their organic processes and their subjective experience and say, one is merely the other. And so when I'm thinking from a holistic perspective, that means that I am taking people's inner lives seriously. That it's not all about symptoms. It's not all about kind of what is on the surface, how things are manifesting, behaviors, say. I really do believe that people's inner worlds, matter. And so when you're talking about working with people in non-ordinary states, they have access to their inner worlds in a different way, and they can bring up images, much like a dream might, that they feel give them insight into where they might be missing something, into what they might need in order to feel whole, right? I might be sitting across from them, telling them that in some really important sense, they are whole already. But if they're feeling broken, sometimes what someone needs is the experience of their very own body and mind and soul revealing to them the fact that they are whole, the fact that they are not broken. And that can be really transformative, right? That's so completely different from them reading in, a book, or having me kind of from even a philosophical perspective, say that that is not the case. And so it's not just about cognitive processes. And that's true for all of psychotherapy, but there's a way in which you're, again, accessing, and it's not exclusive to psychedelics. I strongly believe that you don't need, that the vast majority of people don't need psychedelic experiences in order to access their inner worlds, and heal, from taking their inner world seriously. I really don't. I don't even think that they necessarily, anyway. But it does sort of give you this direct portal into that experience in a way that many people, as we walk through our lives, can't really settle into, can't walk through. And so I really enjoy that. I also enjoy seeing people heal, whether it is sort of the resolution of their depression and suicidality, or healing in this kind of deeper psychospiritual sense. On whatever time frame, that happens. It's just so rewarding to do that. It's so rewarding for me. And yeah, bearing witness to people as they undergo their own transformation, right? They come to me and they're in, they're the caterpillars who have they're in the chrysalis. And in the chrysalis, we completely dissolve the caterpillar. Again, when I say we, I don't mean we. We completely dissolve, right, to our imaginal cells, the image, and and only in doing that can we emerge and become our fullest selves, right? And so whether someone comes to me a caterpillar or in the depths of the chrysalis, I love to be able to support them and bear witness to their, journey, from, one stage into the next.
Thank you so much.
Oliver, do you want to ask your question?
Yeah, sure. Thank you so much for the lecture. It's been very fun to listen and very informative. I was wondering what your thoughts are on the connection between psychedelic use and neuroplasticity or neurogenesis. And additionally, given your background with mitochondria, I was wondering if you find mitochondrial health to be implicated in this process.
Yeah, that's a great question. Both of those are great questions, and I don't really know the answer to the second one. I haven't thought in a meaningful way anyway about mitochondria in many years. I think about them whenever we talk about oxidative stress and things like that, but I don't know, nor do I know whether others do, about the relationship, any relationships between those things. That'll especially be something to be looking at, as people get deeper into the question of inflammation and depression, because when we're talking about those processes, we're often talking about oxidative stress, and so that would be really something interesting to explore. I'm sure some people are already on it that I'm just not familiar with, but I'm sure we can always go more deeply into that. In terms of neurogenesis, there's certainly evidence in preclinical models that blocking the Nmda receptor, including with ketamine, can lead to neurogenesis, or can lead to synaptic plasticity, neuroplasticity. So, that means that the connections between neurons are more dense, that the reinforcement of those connections is higher. And so I don't remember the exact question. I'm going to just talk about neuroscience for a second, though, because I feel like that was where I was going to based on the first part of this. So ketamine is blocking the NMDA receptors. Kind of downstream, a pretty close downstream effect of that is to increase glutamate. So even though it's a glutamatergic receptor that's getting blocked, the cells that, that kind of downstream, I don't even know what the word is, of that are inhibitory GABAergic neurons. And so you're inhibiting the inhibitor of other glutamatergic cells, which leads to an increase in glutamate. Then you have that increase in glutamate, which can target any number of different receptors, one of which is the AMPA receptor, and that is among others that has been associated with learning and memory through synaptic plasticity. And through all of that, through, we think, increasing the production of BDNF, or brain-derived neurotropic factor. And so, there's kind of a nice mechanistic model there, but nobody, everyone throws around this word neuroplasticity, and it becomes, and they might even, they throw it around at different levels, right? They throw it around at the cellular level. And then also when we're talking about psychedelics, it's kind of a word, it's sort of the magic hand waving, neuroplasticity is what underlies, the transformative power of psychedelics across the board. But we don't really know what the connection is between those two things. And so talking about it loosely, I think, does a disservice to these questions. And yet that doesn't mean that we shouldn't be talking about them more rigorously, right? I think that we need to be studying both things, whether they end up with the same name or not. I believe in translational neuroscience. I believe in kind of studying at the different levels and seeing to what extent we can connect those different levels. I do think that if we're using, kind of at a higher level, a higher altitude, using the word neuroplasticity, becomes interesting in its own way, right? Then are we saying our psychology, our inner lives are plastic, right? That the very things that are underlying, that the brain, for which sort of the brain is the organic substrate, that those are subject to change, to evolution. I think that that's why neuroplasticity, is a pretty seductive word there, or at least attractive word there. And I think in that sense, absolutely, that's what's happening. Right, that, or at least within the psychedelic context, and this is true for, say, psilocybin as well, that there is a psychospiritual transformation, at least that is possible there, that can shape the way that people experience and live their lives. We just don't know, though, what the relationship is between those two things, between that cellular level of change and that higher level of change. But it's definitely a question for the future. It doesn't mean that we'll ever be able to answer it, right? For exactly the reason that I was talking about in terms of different lenses and where those lenses, what their orientation is, right? If that biomedical model that's looking at kind of the cellular basis of learning and memory and neuroplasticity, if that's looking at the outside of things, and what we're talking about with a psychospiritual experience is the inner world, the insides of things, I'm not convinced that a reductionistic model is ever going to be giving us insight into inwardness. And so that might just be a case where we will have to use different lenses, where that leap from outside to inside is not going to be able to be, bridged or made by one or the other. That's my intuition. Going back to sort of the history and philosophy of science, much of like modern philosophy of science is not talking about inwardness, period. But that historically has not been the case at all.
Amazing. Kelley Velasquez, she prepared one of the speaker questions, I think, and your hand is raised. Do you wanna ask your question?
Maybe
Yeah, give me 1 second. Let me just pull this up real quick.
I'm going to turn the light on a little bit brighter in here. I'll be right back. It's just right here, so you can help.
Okay. Yeah, so my question was, how does insurance work when it comes to having these sessions, whether that's the group sessions or the individual ones on your page, on your, you have a website. I think it's, I don't know where it's at, but you do have a website. I don't know if you want to put that up there, but I was looking at your website and your information and your practice, and that's where my questions are coming from. And I also had like another question. So it seems that a group, like people that have medical or psychiatric issues, like they seem to be the most vulnerable ones, yet they're probably the most exempt in having these types of sessions because of their history with like mental health and stuff. So my question is more like, what kind of like issues exempts someone from receiving the treatment? And if a patient comes back with adverse effects, how has your practice remedied and supported the individual from such strong reactions? I don't know if there was some confusion with that, so just let me know and I can clarify. Yeah.
Oh, I think those are all lovely questions, and I will at least answer around them. And then you can, follow up as needed. So in terms of insurance doesn't cover ketamine explicitly, or at least not in the vast majority of cases. I think if it ever does, or at least the sort of the shorter term thing will be within that biomedical model, so covering it at infusion centers. One thing that some insurance companies do is cover S-ketamine, which is, well, I won't go into it. Let's just call it a variation of ketamine. It is, for science folks, it is one of the enantiomers of ketamine, the S one, the left one. Some insurances, it's called Spravato, and some insurances do cover that. It also leads to an altered state, but at least as far as I know, nobody's delivering it within a context that actively takes advantage of that. So some insurance companies cover that. Since ketamine is so much cheaper than Spravato, I do think that that some, and probably far more, like I said, will cover ketamine in the future. The problem with ketamine assisted psychotherapy is that even though the drug itself is very, very cheap, psychotherapy is not very, very cheap. And, insurance companies cover that to different degrees. And so I have patients who, have insurance that isn't going to cover ketamine, but does cover some degree of psychotherapy. That, if they have out-of-network insurance, they can often get reimbursement of at least part of it. It still is expensive, though. I think that is in part supply and demand, and in part the fact, and this is sort of the supply part. It is not easy to train good psychotherapists. And so we can't think of it, just train a bunch more, right? Because training takes a long time. Good training takes a long time and is actually an ongoing process. And I think that, that makes it somewhat difficult. That being said, I strongly believe that not everybody needs a therapist who is extremely, who has been doing this for a long time. I think that people need a therapist who is comfortable with non-ordinary states and can support them through those. And I think that in the future, and Rick Doblin will talk about this with MAPS as well, there will be kind of different tiers of treatment that people walk through, that, you know, many people, just like many people would respond to a standard, you know, SSRI like Prozac for depression, right? Okay, great. If that's what you need, or similarly, if you respond to ketamine with two facilitators who are really, you know, there to hold space, they're not trained psychotherapists, if that works for you, fabulous, you know, and they're going to be a lot less expensive because they do have less training. And again, like if that works, terrific. I am all about what works for your wellness. But I think sort of as, you know, if that doesn't work, you know, that people would kind of progress through higher levels of care. But at the end of the day, you know, anything that involves psychotherapy is not going to be cheap. And yeah, I think that that's a problem with sort of mental health parity and how it doesn't exist in our country. In terms of groups, who's the most vulnerable and who might not be eligible, if what you're getting at here is that people with, you know, say untreated psychosis are very vulnerable, then it's true that at least in terms of, you know, when we think about ketamine, say, and it happening in the office, you know, there would be some concern that, you know, that it would be difficult to navigate the altered state and to know for sure that they're going to come back in the time frame that we're talking about. So there's that in the office. In terms of something like psilocybin, say, there was old, so kind of the party line now is that, you know, these substances kind of induce a psychotic-like effect, and so you don't want to give them to people who have a history of psychosis. It makes it, you know, higher chance of them getting truly psychotic, which means, you know, having a persisting false belief or persisting hallucinations, and or that they're going to be at a higher risk of having a persisting sort of like hallucinogen disorder, like, you know, flashbacks, like people talk about with LSD. We don't really know that. There were studies with people, you know, psychotic people, case studies in the past, like in the 50s and 60s, that that might have contradicted that, but nothing rigorous that's been done, you know, at a level like we're doing. The problem with the research studies right now in terms of who's eligible and who's not is that the main goal beyond wellness is to get these medicines into the hands of clinicians. Once they are in the hands of clinicians who can responsibly prescribe and use them, then those clinicians will be able to, you know, try using them in any number of different clinical populations. That would be called off-label use. Now, it's not entirely true, right? There are licensing boards and, you know, federal boards like the DEA that, you know, have certain standards for how we use things, but, you know, but that would be able to happen down the road. So for example, in the Mdma for PTSD trials, you know, there are certain personality disorders that you can't have if you're going to be in the study. You certainly can't have a history of psychosis, say. I would imagine also, you know, bipolar disorder. And certainly that's true for the psilocybin stuff. And often those people really are suffering. So let's say in a psilocybin for depression study, but you have bipolar disorder and you happen to be in a depressive episode, you're not eligible for the study. Well, you know, that's rotten. But in the future, much as they did with ketamine, right? They started with unipolar depression and then tried it out in bipolar depression. I suspect that that will happen as well. But the goal right now is to get it rescheduled so that it's not one of these drugs that is, you know, always sort of, you know, taboo, never, you know, has no medical utility, and a high risk of abuse. That's what it means to be, or that's, you know, how drugs get classified as Schedule 1, to show that the abuse liability and the absence of a medical benefit, that's wrong, right? That there is a medical benefit. And so we say, you know, so you really want like the most robust results in your studies with the fewest side effects. And so if we're talking about, you know, really vulnerable populations, it's possible that you're going to be seeing more side effects. I don't know if you guys saw, there was an article in Salon recently about kind of, I think it was called something like what psychedelic research is doing wrong with psychedelics, or how the biomedical model fails psychedelics, something like that. I apologize to the authors for not remembering. But it was talking about this guy, or one of the things it was talking about is this guy who really, he had PTSD, and he really wanted to be in the MAP study of MDMA for PTSD. And so he was looking at what all the inclusion and exclusion criteria are. And he, when he was screening for the study, he was like, just by the books, right? He said, I didn't want to look, too crazy for the study. Then he gets into the study, he has his 3 doses of MDMA. And at least it is described in this article, feels like he totally fell apart, that he left that study feeling far, far worse than he did when he entered the study, that the MDMA had brought up all kinds of symptoms that, he wasn't accessing in his regular life before he entered the study, that he had been kind of swayed by all of these, miracle stories about how psychedelics and MDMA are going to completely and radically change your life. That was what he was expecting. That is not what he got. I would wonder how many of those screening questions he was kind of, not giving entirely accurate answers to, simply because he really wanted to get into the study. So let's say, he had a history of hearing voices, which is actually quite common in people with PTSD and borderline personality disorder. But if he didn't check that box, because he thought that that would not get him into the study, the reason that box is there is that there's a concern that they would be higher risk. And what does higher risk mean? It doesn't necessarily mean that, they're going to completely, lose their, sense of consensus reality. It means that they're probably going to at least need more support, whether that's more support in the form of more sessions, more intensive psychotherapy, or what, we don't know yet. But, for these studies, we're really trying to get clean results that, that help people without hurting people in a way that we really can do it by a specific protocol. And so kind of the more unusual, the person who's coming into things, or coming into a study like that, the more unknown. And researchers don't tend to like the unknown, at least outside kind of their primary outcome. So in part because of safety concerns. And so, one of the things in this article that the guy said was, what really helped me after I left was more psychedelic medicine in the underground setting. And so that was a nice example of how, once these drugs are rescheduled and clinicians are able to use them, people won't have to use them in the same protocol as they've, used them before. And so, there will be a lot more of an opportunity to use them in potentially more vulnerable populations, as long as what we mean by vulnerable is not something that will, look like them ending up in the psychiatric emergency room. Like, what it means to be vulnerable and what it means to benefit from these medications, and sort of on what time frame with what protocol, those are all still questions that we don't know the answer to. And so, yeah, that's really tricky. In these studies, we're looking for clean results so that we can get them in clinicians' hands so that more people can benefit. And then after that happens, we'll be able to, get more creative about how we do the therapy, how many sessions we have, and things like that, and even, who qualifies.
I think we have time for one more question. So if Johnny wants to ask his question, you can.
Yeah, I was wondering if there's any one patient in particular, or one experience in particular that stands out to you of somebody who's where this has had a profound effect and it's been life-changing, and maybe you've taken something away from that.
That's a lovely question. Yeah. Putting me on the spot is hard because there are kind of two, I wouldn't say kinds of patients, but maybe kinds of transformative responses that I find rewarding. So on the one hand, there is, I've had a number of patients in an acute depressive episode who at least, after a single session, like at least 24 hours later, but almost immediately, like that's radically changed. And so I treat a woman who, with sort of integrated psychotherapy as well, but included among those things is ketamine-assisted psychotherapy, with PTSD and depression. And her depression can lead to suicidal thoughts, that really a single dose of ketamine, even if it doesn't treat her depression itself, gets rid of the suicidal thoughts, which, is literally life-changing, potentially, depending on the severity of the suicidality. And then, over time can radically transform their, the mood, and the symptoms associated with that. And so that kind of experience is very, very rewarding for me, because one's mood and one's symptoms really do affect how one lives their life, right? Even, can they engage in therapy or not? Can they engage in a meaningful relationship with their partner and with their kids and things like that? And so, so really just at that symptom level, it can be extremely helpful. And then I also really do, and these are actually kind of longer term cases of ketamine assisted psychotherapy that, that are coming to mind when I think about just how rewarding they are. People who have had they're often in middle age, who kind of suddenly discovered, it's an insidious sort of discovery that the way that they've been living their lives doesn't feel all that meaningful. If it ever did, it certainly doesn't anymore. And it's possible that they were never thinking of that question in the first place, until they started feeling depressed and things start, and their depression wasn't getting treated by medication. And, whether we're talking about psychedelics or not, I always love to talk about meaning and how people find meaning in their lives, and what they feel might be missing in their, in their outer or inner lives, that can enhance an experience, not just sort of an idea, but an experience, a lived experience of meaning. And so, so for that, often, the ketamine experience itself can be very disorienting, but give them very powerful images that they're not entirely sure what to do with. Again, these are people who might not have even realized that the inner life was a thing, before they started coming to me. And then they have these experiences, and we are really taking them seriously, taking the images seriously, trying to learn from them, and watching over time that process as somebody really comes to discover themselves, to discover their, these parts, the shadow in Jungian language, these parts of themselves that they've been closed off from for any number of reasons, and to really kind of gently coax them out, in an ongoing way. The integration there is really, really rewarding to me, and that, that can be transformational in a completely different way, but is often also associated with symptom, improvement. Yeah. I know we're out of time, right?
Yeah, unfortunately we're out of time. But thank you so much for this talk and for answering the questions so thoughtfully. And usually we end class by asking if you have any final words that you would like to leave us with, or any knowledge that you would like us to carry with us as we leave today.
I think we've touched on so many things that are important to me, that are getting at sort of this relationship, right, between knowledge and wisdom. And if you read the second paragraph of my, silly bio, it is addressing, or it's getting at questions that I think are really important to me, some of which people do try to access through psychedelics, in terms of what does it mean to live authentically? What does it mean to live a life that feels vibrant with meaning? What does it mean to live with dying? And how do we keep those things in our minds and in our hearts, and allow them to engage with, with ourselves, or have them help us to engage with ourselves and with other people, and with the world, right? And that kind of gets back to this question of, what is the scientific lens? What is a philosophical lens, a spiritual lens? a psychological lens, all of these different things. What is it that we are really trying to discover? Who is it, and what is our relationship to that? I think that, one of the things that I've loved about all of these questions that you guys have brought up is that, that's what you're doing, right? You're looking through all of these different lenses. And insofar as you guys are all in this one class, I'm at least experiencing you as really being interested in the whole, and kind of taking these different views of things at one after the other in an effort to see the whole and ultimately to see your part in that whole. And so I would really encourage you to think about these things not as being separate from each other or from you. It's one of I love the image of like mushrooms in the mycelial network, right? That above the ground, the mushrooms look like they are separated from one another. But if only you dig just a little bit, right? You have to go beneath the surface and you see that they are entirely connected, that they're a single organism in that sense, connected through the mycelium. I think that that's a really powerful kind of living symbol, both for our lives and our relationship with each other, but also, science and its relationship with what it is that we're trying to understand. Yeah. I feel like now's where Anna's supposed to say.
Yeah.
Talks a lot again, but now we're really out of time.
Now we're really out of time. So yeah, thank you so much. And we really appreciate this whole lecture.
Thank you for
we
having
hope to
me.
speak to you soon.
Oh, sorry. You guys like. Bye.